Hello and welcome to SimCast, the higher education simulation podcast. My name's Lawrence Hill and I'm the chair of the simulation group in the School of Health Sciences at UEA Norwich.
Hi everyone, my name's Tony Jeremy and I'm the academic lead for simulation-based education here at UEA Norwich.
Welcome back to the podcast. Today we are joined by Juliet Harrison.
Hi Juliet.
Hello.
Thank you so much for coming on. Juliet is an associate professor in paramedic science and a doctoral research student, and I have to say, long-term colleague of mine on the paramedic science program at UEA. And today we're going to be talking about promoting equity through diversity in simulation.
If you enjoyed the episode, please give us a like. Equally so, if you didn't like the episode, give us a dislike, but let us know why in the comments below because we're always keen to improve. To keep up to date with all things sim-related, check the subscribe button. Don't forget to hit that notification bell.
Please do like that, like our podcast and subscribe. So, Juliet, tell us a little bit about yourself. Like, what's your clinical background and how did you get into higher education?
Okay, so I've been a paramedic for a number of years, probably more than I'd like to mention, but I worked initially at the East England Ambulance Service, and before that I took a degree through the Open University in biology and chemistry. Then I went on and trained as a paramedic and then came into higher education 10 years ago and joined the paramedic program here at the UEA when it first started out and when we first sort of got the program
10
running.
years, wow.
I know, I can't believe it's been 10 years already.
I know.
A decade of terror. As an associate professor in paramedic science, that counts for me too.
Yeah, I mean, it's been a good 10 years here.
Yeah, it's been great. So what's your role now? So what do you do at UEA?
Well, I teach a lot of anatomy and physiology. I'm involved in a lot of simulation for the paramedic team, mainly. I'm also placement lead, so like several things, and I teach across all 3 years of the program.
And for any of our learners who might be watching, what else do you do that they might not be aware of?
Gymnastics, I guess.
Okay.
It's not usual for a 50-plus woman, but I really enjoy my gymnastics.
Excellent.
So, yeah.
You've been a gymnast for a long time though, haven't you?
Yeah, on and off. So yeah, I did it in my teens, then I stopped, had quite an injury, and then I kind of went back to it in my 20s, then I stopped, and then I went back to it when I became 50. So yeah.
And maybe that's what makes you such a flexible educator.
Dear.
So anyway,
that's terrible.
That is terrible. That's bad. So
let's get on to the main topic.
Yeah,
I think
let's tumble into the topic.
Just stop.
Okay, sorry.
So we're going to be talking today about promoting equity through diversity in simulation. So, Juliet, what gives it an oversight into your research activities about this and why this topic?
So I'll start with why this topic, and I guess that was several years ago. I was teaching a group of year ones, and I was talking about capillary refill, and I kind of held up my finger and went, "Oh yes," and then you look out for the pinking up after the 5 seconds, and I just sort of looked around the room, and I just thought that's just an entirely inappropriate thing to say. I had an audience who had a variety of skin tones in there, and I thought this is just doesn't seem right to me. And from then I started out researching. I apologised to the group at the time, said I think what I just said was wrong. I want you to think about it as a change in skin colour, because as the blood returns to that area. And then I started to look into it more and more and realised that there was just very little out there. And actually, traditionally, that our background in the way we're taught in healthcare is very much about white skin orientated. So you look in textbooks, the pictures are all white patients. You look at rashes, it's all white patients. So I got my interest from then, and then went on to start a PhD, and also trying on this program, on our paramedic program, to introduce more understanding and better teaching so that there's less of kind of bringing in the diversity section at the end of a teaching session. So what I've read in my research is it can happen in certain courses that you kind of have a 3-hour lecture, and like the last 10 minutes of it will have a couple of slides which are added in as an extra, rather than it just being embedded through the whole as it should be. That we shouldn't see diversity as an extra thing. It should be just there as a normalised part of teaching. Yeah,
and that phrase that you referred to right at the beginning there, that the pinking up kind of thing is it's ubiquitous, isn't it? In healthcare, it's like
and in simulation, isn't it? You know, if you think about A3 assessment, how many different learner groups do that right from day dot, and it's that kind of clumsy terminology that just ingrains that poor practice.
Yeah, particularly I think right from the beginning, you think about when you're setting up a sim and somebody comes in and says, I'm asking about the patient, how do they look? And generally there's a lot of terminology around like pale or blue or grey, without any thought about the fact whether everybody would present in that way. So it's also about changing the terminology to saying something like the patient's got reduction in their normal skin colour, which would cover everybody, without automatically diverting to what is traditionally in textbooks and actually maybe shouldn't be anymore. We should be looking wider.
Interesting. Yeah, that is interesting. So we're at, it's not just semantics. It's not just about, what is the correct word, excuse me for saying this, but it's actually what that represents, and thinking critically about the words that we use to describe skin tone and skin colour during assessment. And that can be tricky in simulation, right? But before we get into that, how does this deficit, if that's the right word, about talking about matters that affect human variability and diversity in training affect practice?
Well, there's very little evidence that it directly does, but I think it must do at a personal level. I don't see how you can omit something out of some teaching and then expect people to just know it by osmosis, if you like. So what I found, I did a scoping review last September in 2023, and what I was looking at is the confidence of clinicians in assessing all skin tones equally. And to begin with, I was looking at paramedics, and I couldn't find any evidence at all. So then I literally just looked at any healthcare professional, and even with that, I still only got 13 pieces of evidence that were of use for me for this scoping review. But fundamentally, what I found is that people are generally lack confidence in assessing patients of all skin tone. And this was coming back to their training, which of course includes simulation. So yeah, I'm not sure how good it is in practice, but what I do find is if somebody works in an area where there's lots of diversity, there's lots of skin tones, that the clinicians there will find a way, they will get better, and they will pass on that knowledge to their students, which is excellent. There's nothing formal in that. It's just if you happen to be in the right place at the right time, someone will show you. But if you were to work or as a clinician in an area of the country that's, say, very white-skinned based, that would be less so.
The east of England, the northeast, the southwest, there's areas of the country that have just got considerably lower levels of ethnic diversity and then diversity in skin tone.
Absolutely. And arguably you'd then say that the people who do live there, who perhaps say somebody with black skin lives in that area, that they're perhaps more at risk because the clinicians that see them haven't got that experience or any experiential knowledge that they've gained over time. So.
And there are, although it might be difficult to demonstrate the causal link between training experiences and healthcare outcomes, there are unquestionably healthcare inequalities, some of which came to light during COVID, right?
Yes, absolutely. I mean, you could put multiple reasons. I'm sure there are multiple reasons. I mean, one, you could say that perhaps the NHS has still got institutional racism, but I think it's also about a culture of using the same terminology, of still using your pinking ups, your blue, your grey, that kind of reinforces it. And we've always done it this way, so why are we going to change? It's always difficult to get change in motion. But yes, particularly for, I'm sure you're probably aware, but the mortality was higher in certain ethnicities, for example. And my argument in my scoping review was that if you haven't trained people to spot the really early signs of when someone's deteriorating, then they'll be picked up later. And if you don't know how to look for peripheral cyanosis, for example, in somebody who has black skin, and you're missing it till it becomes central, then you've missed that early point to make that intervention of give that oxygen. And to add into that, there's in the last sort of 4 or 5 years, there's increasing evidence around pulse oximetry, which says that it's not as effective or not as reliable, certainly in dark skin tones because of the higher pigmentation, so the infrared doesn't work as well. And I know that in the US, certain companies are now making pulse oximetry to match that. But the fact is, if you would put a pulse ox on a patient that seemed to be breathing fairly normally, but actually had COVID and it wasn't picking up what you expected because you haven't got an arterial line in because you're at home, because you're a paramedic, you could be making a judgment which is actually incorrect. So my argument would be that maybe that has played a part in what's happened in COVID. I mean, I haven't got any evidence, it's just my theory.
So just for clarity, the darker the skin tone, the more likely a oxygen saturation probe is to read a higher reading because of the relative absorption rates of different wavelengths of light, which is used to measure pulse oximetry. So patients with darker skin tones, as I understand it, are likely to see a higher oxygen saturation according to pulse oximetry.
Indeed. Most of the studies that have been done on this are usually in sort of intensive care, so where there's an arterial line in place rather than pre-hospitally for paramedics, for example. But the information's there. And I mean, there's also the fact that pulse oximeters are not 100% reliable, nail polish, cold hands, all the rest of it.
Yeah.
But it's just one more factor that needs to go in. And literally in the last couple of weeks, in March 2024, there's been a review that was an independent review that was set up by the government, and it's been run by Professor Whitehead. And that team have looked at medical devices as a whole. So pulse oximetry is just one of them, but their findings in the last 2 weeks is that they are not reliable in dark skin tones, and one of their recommendations is to ask NICE to relook at their guidance on it. But also, I'm assuming pushing this back towards NHS Trust to look at.
And pushing it back towards simulation educators.
Yeah, well, so as educators, there's obviously an inequality in our curriculum as well, and the design of it. And as simulation educators, we have an opportunity to try and correct that where we can, where we have influence on the curriculum. So what would a kind of an ideal curriculum look to you, and what sort of barriers do you think we might face?
So an ideal curriculum to me wouldn't have like a diversity section. It would just be part of all the sessions you teach. So I would suggest that you want to be normalising what is actually normal population. Do you see what I mean? I mean, by 50-51, England and Wales are predicted to have 30% of their population will be of a dark skin tone or brown skin tone. So I'm not sure why it's not sort of more embedded into healthcare for that expectation. So
rather than a one-off session.
Indeed.
Which is what happens sometimes if you're lucky.
Indeed, it's just there as part of it. We're going to look at a range of skin tones for this. We're going to use a range of skin tones in simulation, and added into that just any type of diversity. So thinking about people who maybe their sexuality, their gender, whatever it is, just making that the norm. So it reflects the norm that we are as a society.
In the same way that diversity of age is just totally integrated into curricula, like it's totally normalised, isn't it?
You speak to the children and young people's nurses, I think they might disagree with you on that.
Fair. Maybe we should get them on to have that conversation.
But actually, so going right back to that sort of terminology that we're using in simulation as well, and this is probably another episode that we probably need to look at, is the language in simulation. It certainly needs to be looked at from an equality and diversity point of view.
Yeah,
it's quite an easy one to start with, isn't it? Just to think about what it is that you're saying, and is it appropriate for that patient? But also, could you not just use a generally inclusive term that could be applied to everyone? So again, it's making it all the same for everybody. So a systematic approach to a patient would be the same no matter what their skin tone. So otherwise you're separating people out into groups. Again, you're just othering people, aren't you?
No, I'm all in favour of this sort of principle of kind of liberal humanism and treating people as individuals rather than as but having a critical understanding as well at the same time about what some of the challenges may be from an epidemiological or genetic standpoint, because there are going to be some variation across people in terms of how they present, and introducing that as a matter of course into simulation and other healthcare curricula, as you're saying, is integral to helping to address some of those healthcare inequalities. Yeah,
and I think it'll take time. It's not something that happens overnight. I mean, there was a study by Ferronda et al. In 2020 that was saying that basically simulation mannequins are not really suited across the board, as in they tend to be a white mannequin, which could be perhaps male or female, usually with plastic hair and sort of staring eyes, and not very realistic in that sense. And I think in the last 4 years, we have actually moved forward. I mean, my experience of seeing what is available now has shifted in terms of everything, not just skin tone, but just in the whole look of the patient, older patients, for example, as well as younger with various disease processes, which makes it far more realistic. But I think if you only have a set of kind of white mannequins, that perhaps you ought to be looking at how you could change that and actually get some more diversity into what you've got.
With the, the cost implication involved with it, of course.
Indeed.
That needs to be considered. We'll put a link to that study in the comments below so that people can have a look at that. It sounds really interesting.
Yeah, it's so in the School of Health Sciences here at UEA, as you well know, we intentionally purchased a fleet, if that's the right word, of mannequins that have a variety of different skin tones.
But even then, at the time, there are still different skin tones that were unavailable that the companies were in the process of developing. So they're playing catch up as well.
But it's nice to know they are.
Yes,
do you know what I mean?
yeah.
I think originally, I don't think there was. But it's even like you can get those little sort of, I'm going to call them little skin that you just literally for injection.
Mm-hmm.
Part-task training.
They tend to be sort of like a peachy pink colour, don't they, rather than anything else.
Yeah, and I'm sure that they can be accessed in a variety of different tones as well. And if not, then it would be helpful if they were. But in what ways do you think that this diversification of the skin tone of plastic mannequins is helpful? Like, how does it help as educators and as learners? But also, do you see any kind of challenges associated with simulation as a vehicle for talking about diversity?
I think it's helpful. I don't think it's particularly helpful for students of different ethnicities, because I think from the research I've read, where there's been, for example, a cohort of, say, 20 white students with one black student in there, when diversity isn't mentioned or addressed, that one black student finds it incredibly difficult to stick their hand up and say, actually, I don't think that's okay. And actually the 20 white ones don't necessarily notice the problem, as does perhaps the lecturer as well. And I think that by just having it there, it just makes it more equitable for everybody without it being a big deal where somebody's kind of singled out as, and when they shouldn't be. Just so I mean, it comes back to what I said about normalisation. It just should be there as, okay, today we're using a white mannequin, today we're using a black mannequin.
Right.
It just is interchangeable depending on the scenario, without using the sort of stereotypes that can also jump in, that sort of tokenism around, making assumptions about people's skin colour in relation to their culture or their religion, for example, or their name, whatever it is. It's because, again, I think that can easily happen when people are writing scenarios.
People have a tendency to ham things up, don't they, when they write simulation scenarios, and you don't want to put ethnicity or gender or race into that.
Indeed. I mean, yes. I mean, if you look around you and talk to people you know, that isn't the case, isn't it? So I don't know why we have to use those stereotypes in simulation.
No, I like that. Thank you. That's a really good point. So it's having mannequins with a diversity of mannequins is perhaps almost serves as a trigger to normalise that conversation about how normal human variation needs to be accounted for in terms of the practice of whatever the healthcare discipline is. So rather than putting it down to the individual who may kind of have a darker skin tone or something to sort of raise that point, it's there, it's evident, it's part of the simulation that way. So it's not as awkward for anyone to raise that point. So perhaps that's partly why it's useful. Yes,
I think so. I don't think when you have your students, I don't think they should have to feel that they've got to speak up and make those kind of comments for themselves. And, why should you have to? Any more than you should justify anything about yourself. If you've got a characteristic, whether it's protected or not, why should you have to justify that, I would suggest. And like I said, that also overlaps, as I said, into other protected characteristics. Should you have to justify if you're pregnant, for example? Do you know what I mean? So, yeah.
No, good point. Great. So there's clearly advantages, but there are also limitations, aren't there, in terms of these mannequins still? I mean, like you say, it's useful to have a mix because it introduces, the opportunity for dialogue. But how real are these mannequins, and does that do the deficits in realism kind of contribute to this issue?
And also, we keep talking about mannequins, but a lot of simulation we use simulated patients, don't we? Confederates, actors, whatever you want to call them. And again, if you go use your example of having 20 white students and one black student, we always having to pick on the same black student to play that token role.
Yes.
To ensure diversity in our simulation. So we might have some limitations there.
Yeah. I mean, if you're that student, that'd be horrible, wouldn't it? I mean, I put myself in that position, and I think that would just, yes, just completely wrong on every level, isn't it? To think of it to go down that route.
So challenges with simulation in terms of getting to that point where it's just kind of commonplace and embedded?
For me, I think some of the challenges are that it's uncomfortable because people don't want to make a mistake and inadvertently say or do something which could be construed as being racist or prejudicial. But it's actually without having that conversation, it's very difficult to then make some progress forward.
Yes, I can't right this second remember who it was who wrote about something called colour blindness, where people are so eager not to seem racist that they will ignore somebody's skin tone, which I understand, but also not if it's going to actually affect them as an individual. So it's it's looking at both sides of that, really.
Yeah, so it's a really interesting area and a really important area that we develop, but it's definitely one which is ripe for research. So I'm so pleased that this is an area that not just you but lots of people are thinking actually we really need to address this. So that's really important.
Yeah, I think in the last couple of years, and maybe because of COVID, I think things have escalated in terms of understanding, but also since the information called Mind the Gap, which is a little handbook on assessing black and brown skin, came out as well. That has also helped, but there is more websites out there. So I'm going to say, don't forget the bubbles. Skin Deep, it's called, which is a paediatric website. It's got some excellent sort of resources on there to help with like skin rashes on all skin tones. But that kind of thing has escalated, which is good. And I know there's a particular thing going on in Bristol at the moment where they're encouraging photography of various conditions on people of all skin tones, so they can actually increase what is out there. Because as I said, textbooks lean towards white pictures, and if you haven't seen it, how could you possibly recognise it? And I think it's also about changing the way that people assess, which would be part of simulation. So thinking of different routes. So for example, if you're looking at someone for a rash or you're examining their fingers for peripheral cyanosis, that you remember to try and use natural light where possible and avoid fluorescent light, because that puts a blue tinge on things anyway. Also actually feeling for the rash, feeling for the heat. So seeing if the skin's more stretched and more shiny, for example. It can change colour and become darker if someone's got inflammation in that area rather than automatically becoming red. So it might be more of a purple colour. And if somebody's really unwell, you may not necessarily see it. There will be a change in their skin colour, but if you haven't met them before, you may not notice it as clearly. So the thing to do is look at people's palms and look at the creases of the palms and see if there's palmar pallor. That's one way of helping with that. And using terminology like pallor instead of pale, for example.
Sure. Which might seem like a small semantic difference, but actually, may represent something quite different.
That brings me on to kind of my next question is, if, for the simulation educators that are either watching and listening to this episode, we've identified that this isn't going to change overnight. It's a marathon, it's not a sprint. So what sort of quick wins do you think educators can do to build into their simulation design or curriculum influence to sort of start moving in the right direction?
I think automatically, if you've got any pictures in your scenarios or your information that you're passing around, that it should have more than one skin colour in there, one skin tone, sorry. I think also that when you're running a simulation, think about what terminology you're using. That would be the quick win instantly to look at the whole picture, look at the patient. But also if you're, for example, doing your ABCD approach, thinking what I said about palm colour, looking at palmar change. But also trying to embed things like I've said about using the right light to examine things, examine your patient. If there's bruising to be looked at, make sure, again, same thing about the light. And try to use the word skin colour when you're talking about the change in skin colour and skin tone, about actually the person's skin tone that's set up by the pigmentation, the melanin that they've got in their skin, that we're all as individual to everybody, and trying to differentiate those. So because everyone's skin colour does change when they're unwell. So
Okay, great. So that's really helpful. And also what we'll do is we'll put a link to the Mind the Gap resource, which is a phenomenal resource. And please do check that out if you haven't come across it yet. It is a great resource. Okay, super. Well,
it's been really interesting.
Yeah,
really interesting.
Really thought-provoking. And And I think it's one of those things where you perhaps when you start to think critically about the things that you do in simulation and sort of challenge your assumptions, I suppose as educators we might find that there are more and more opportunities to adapt or evolve curricula in a way in a kind of a piece by piece manner that just makes those small incremental changes that leads to a more inclusive simulation curriculum. So that's really good. Thank you so much, Juliet. I think we're probably getting to the stage where we need to think about wrapping this podcast up.
We could probably talk about it for ages, couldn't we?
We could certainly continue this conversation more, and perhaps we should do that further when you've
completed your PhD.
Completed your PhD. That would be great. But before we do close, what advice would you give to our viewers? What guidance or what kind of personal reflections would you have about using simulation as a tool for teaching and learning in relation to diversity?
I think the biggest thing would be to look at your scenarios and think, are you being tokenistic? Because I think, or stereotypical in your presentation. And then when you've thought about that, have you actually represented the wider population in what you're doing? And then thirdly, your terminology, because I think that's just such a quick thing to start being inclusive with it, and it shouldn't really change that much. It's the subtlety here of just making that.
And I guess every simulation centre or HEI just needs one champion to sort of start promoting that and then spreading the good practice throughout the rest of the faculty.
Yes, I mean, when I talk to clinicians and I sort of describe what I just have about, how to assess, they're all like, yeah, makes sense. And it doesn't change anything. You just use the same approach regardless. So it's just about a few subtleties, isn't it? It's,
Great. Thank you very much, Juliet, for coming to speak to us today.
Thank you.
It's been really, really interesting.
Thank you, Juliet. And thank you for listening in. Really appreciate your ongoing listening into this podcast. We hope you've enjoyed this one, and we hope it's given you something to think about. If it has given you pause for thought and reflection, please do drop us a comment below, and we'd love to hear what you've made of today's podcast. We'll see you on the next one. Bye for now.
Thanks, everyone. Bye-bye.